Right.
So just Smithers. That's all right. That's when we get the recording started, so I don't miss a few words if you didn't like sometimes I do. That's an awesome picture. You get that tattoo right there. I should next year put instructor and then student.
That's a little disturbing.
What's that?
That's a little disturbing. That would look like it would hurt. A lot.
It was not my birthday.
Yay.
He's turning 44 tomorrow.
Yay.
Just harass him, 24 hours.
Anyone else fill out?
Yes, I have t-shirts on. You tell me.
Trying to be like,
All right, it's a little past 11, so here we go. So in this block, we're going to discuss the physiology of pain and what are 3 classes of drugs that you treat pain with? Opioids, local anesthetics, and NSAIDs, right? Aspirin, Motrin. Now I thought this was a very cool picture to kind of give you some comparisons on the quantification of pain. Right? So a woman who has never had a baby before states that giving birth is pretty painful. I don't know how they compared it to digit amputation, but apparently getting your finger cut off and having a baby for the first time is pretty similar in the pain response. Pretty similar. I have post-herpetic neuralgia. I would not put it at a 20. When it flared up for me, I couldn't sleep for 3 days. So it was pretty painful for me. But what does that tell you about pain? It's individual. It's subjective. It is what that patient says it is, we've always learned. Now, in 1979, this definition of pain came out, which states that pain is an unpleasant sensory and emotional experience associated with actual or potential tissue damage or described in terms of such damage. That's a pretty generic definition of pain. Bottom line is pain hurts. So this slide should look familiar if you watch the video. And we're going to run through that pathway real quick. So the first thing for pain to be sensed is what has to happen. You've got to have that noxious stimulus. I pour hydrochloric acid on you. I hit your toe with a hammer. Right? You cut yourself with a knife. Something has to happen that gives a signal to a bare nerve ending, right, to a Rufian corpuscle, I believe, a Merkel disc. Something has to happen in which an alpha delta for sharp pain or a C fiber for that chronic pain are activated. Now, what do we know about afferents? They go to something. And so this primary afferent neuron, also known as the first order neuron in this pain pathway, the receptors receive the stimulus and transduce it into an electrical message. That electrical message is then transmitted to the dorsal horn of the spinal cord. And from there, either the C fiber or the A delta fiber, depending on what fiber you're talking about, is going to synapse in 1 of 3 lamina. Right? 1, 2, and 5. The one is known as the jelly substance. Is that 2? Two. I think it's two. There you go. Now, that stimulus may be transferred to an interneuron, or it might be transferred directly to a second-order neuron. If it's transferred to an interneuron, as annotated in purple here, it might receive some modulation. Okay. And what would be an example of an interneuron then? Or an interneuron actually not transferred to it, but it might intercede. It might intercede in that mix.
Like a reflex arc.
So if your endogenous pain mechanism, right, you can have another interneuron or neuronal connection that might try to dampen that painful stimulus as it comes in. So just remember that the dorsal horn is this hub where many things connect. But it is where the primary afferent first-order neuron will join up and transfer the signal after some modulation to the second-order neuron. Now, this second-order neuron is going to be part of one of three tracts, at least one of three tracts. But we're going to focus on the spinothalamic tract, the spino-reticular tract, and the spino-mesencephalic tract. The spinothalamic tract is what carries the impulse to your somatosensory cortex. Or anyway, it stops in the thalamus prior to going there, but that is the tract in which you perceive and localize that pain. The next tract is the one that I kind of say makes the hair on the back of your neck stand up. It heightens your awareness. It is where you get stimulus that goes to your reticular activating system and increases your awareness. Now, perception is different than awareness. If I perceive something, I sense it, I feel it. If I'm aware, my senses are heightened. Does that make sense? Anybody have an issue with that? Okay. And then finally, as soon as I get hurt, my body wants to try and blunt that noxious stimulus. So this primary afferent neuron will also synapse with a second-order neuron that's part of the spino-mesencephalic tract. And that tract is the descending, we begin the descending pain pathway. It goes up to the pons and the medulla, and it comes back down. And you saw that video, and we're going to discuss that diagram later on. Now, once we hit the second-order neuron, where are we headed? Up and to the thalamus, the relay station. All three of these tracts do make stops in the thalamus. But there is one of these tracts that has a component of it that never reaches the thalamus. That's the spino-mesencephalic tract. And that tract is either going to have 2 or 4 neurons that are part of its pathway. And as we go on, I'll explain it. Now, once we get to the thalamus, our message arrives at the axon terminal. It is transduced into a chemical message via the vesicles. They're released onto the third-order neuron dendrite. That third-order neuron dendrite creates IPSPs and EPSPs, enough to create a local potential that turns into an action potential. And then that is transduced to the somatosensory cortex. And if you all remember your sensory homunculus, you can, if I hurt my toe, then I'm going to a certain part of the brain. If my wife likes to come up and tweak my nipple, then, that's another part of the brain. I don't know why she does that. I hate it. Huh? She just being TMI? All right. But I bet you remember it. I can't get that visual out of my head. All right, this is the stress that in the dorsal horn. A lot of things go on. Now, there's 2 types of pain. There's acute pain, and then there is clinical or chronic pain. Acute pain can turn into chronic pain if the stimulus is sufficient enough. If it is a huge stimulus at once, or if it's a constant stimulus over time. Your dorsal horn will undergo changes that will create a condition in which you make a memory of pain, and thereby facilitate transmission of pain easier. That's called central sensitization. We'll get there as well. So pain isn't pain until it gets to the brain. In fact, we look at those strategies to try to treat pain with nerve blocks or with actual dissections of nerves to stop pain. Many things can cause pain. You have different channels. You have channels for cold. You have channels for heat. You have channels for acid. You have bare nerve fibers that respond to sharp cutting sensations. Now, why do you have pain? You protect yourself. You are sensing something that might harm your skin. Skin's an organ, so if that comes under attack, we're going to remove away. This is a reflex. Think about this. Why do you have a pyramidal decussation?
So we pull back our muscle.
You're going, you hear it on one side, you try to get away on the other side. Right? You come up, you sense it, you move back down, and you're going to try to move away from the stimulus. That was a question that was asked of me in my dissertation defense, and I was like, I don't know. But the thought is that it is the crosstalk, the decussation creates a condition in which you can move away better, more efficiently from painful stimuli. Here's an example of different types of receptors. You don't need to know the names. Just realize that each of these stimuli have their own unique receptors. And they're all along the receptive fields along your skin and your organs. And they will respond. They'll all be a component of that first order neuron. So imagine that neuron, many dendrites, on those dendrites, many types of receptors, many sensing stations. Who here has put themselves in a cold bucket long enough that it begins to hurt? It does hurt. All right, acute pain. Acute pain is fairly simple. You get a stimulus. You activate your first order neuron. You depolarize the axonal terminal. The voltage gated calcium channels open up. The glutamate via vesicles falls into the synapse. Maybe some substance P, but this is just a one-time stimulus. You activate some of these ionic channels, the AMPA, the kainate, the NMDA receptor. But what is going on while the activation is occurring? Is glutamate diffusing away from the synapse? Is it being reuptook? There's mechanisms underway to help remove that neurotransmitter from the synapse. So this depolarization is relatively short. But it still hurts, right? You're still going to move away. Get yourself, because if you don't move away from the stimulus, you're going to keep filling that synapse with glutamate. And if you keep filling that synapse with glutamate and ultimately substance P, let me make the point real quick, you're going to find yourself in that condition. You're going to find yourself in that condition where you start making changes along the dorsal horn of your spinal cord. So the changes, the plasticity of the dorsal horn of the spinal cord, in which chronic pain can be created, is dependent upon the length and duration of glutamate and substance P that remain in the synapse. So in a nutshell, the longer you hurt yourself, the more prone you are to having central sensitization and chronic pain. The more substantial the injury, all right, the more prone you are to have clinical chronic pain. Does it always happen? No, but it sets you up for it. Now, why are we in anesthesia so worried about pain? What kind of things does it inhibit? Ventilation. If someone's hurting and they're splinting, they don't fill up their lungs. And if their lungs don't fill up, what do they develop? Paralysis. They lose a portion of their lung for air movement. It also is going to activate neuroendocrine mechanisms that are going to inhibit wound healing. If your sympathetic nervous system is vasoconstricted, can you deliver substrate to the wound as efficiently as before? No, you cannot. So the bottom line is, if you don't adequately treat the patient's pain, you're going to make the condition worse. That's kind of common sense. But this is a nice slide to kind of look at it as a systems process. Now, chronic pain. I remember sitting in your seats, and Dr. Christie doesn't remember this, but he's going over the pain pathway, and he starts talking about the A delta and then the C fibers. And he goes, those C fibers, those burning, aching, chronic pain pathway. And I'm like, who's up there with a German accent? What's going on? So he says he never did it, but I was sitting there. I know he did it.
Last week he did it.
Yeah.
He explained why too. He had a German teacher.
Oh, okay. But he goes, I don't remember that. Why did he say that?
Now we talk about pain.
Now we talk about pain.
Yeah.
So I can relate. But chronic pain. Chronic begins with a C. C fiber. Right? C fiber. That's what's going to carry this long-term, just achy, this pain that just drives you crazy. It's like the water dripping on your forehead over time. Right? This pain lingers. I think we get this part. Now, it does cause a condition called hypersensitivity or hyperalgesia. What do you think that means, Brian? Easier to get the same response, or what's the term a different way?
Takes less.
Well, how about an equal stimulus is more painful? Right? So, what about allodynia? Have you heard of that before? Usually, if you brush your skin with your hand, it doesn't hurt. But if you get a sunburn, brush your skin with your hand, it hurts. So allodynia is when a normally non-noxious stimulus is now hurtful or noxious. It is this sensitivity, this difference in sensitivity, that distinguishes physiologic pain and clinical pain. Physiologic, reflexive, acute pain versus this chronic, neuropathic, clinical pain. Let me give you an example. So chronic pain is usually as a result of peripheral and or central sensitization, or central sensitization and or peripheral sensitization, however you want to say it. But you've got some key points that happen. So imagine you're going in for surgery. And I'm the surgeon, I take this knife and I rip you open from sternum to belly button. Or I just go and do a little appy. I don't know, same thing. What's going to happen to that surgical site? It's going to get red. It's going to get inflamed. It's going to be part of the normal process. And if I don't adequately treat your pain, those mediators of inflammation that I released when I caused that tissue injury are going to sensitize your peripheral receptors, your peripheral nociceptors. And it's going to make them easier to fire. Okay? Because what do we know those mediators to be? Potassium, hydrogen, they're ions. And what do ions do to potentials? They screw them up, right? That's a good term, screw them up. Now this is going to cause this phenomenon known as wind-up. So these peripheral nociceptors that are now sensitized are going to do what? They're going to constantly start pinging, kind of like a clock, right? So imagine that the surgical incision is when you wind up the alarm clock. Right? You let it go, and you start hearing the ticking, the peripheral sensitization, and it just pings a response to the dorsal horn, sends this continued stimulus, this boring stimulus. And what is that? What is that pain fiber? C fibers. Now, the surgical incision itself sent a painful response of what fiber? A delta. A delta. Now, I start releasing all kinds of glutamate and substance P into the dorsal horn. I start to make these plastic changes. And they call it plasticity because plastic can bend and roll. So I start inducing this plasticity into the dorsal horn, and now I start creating more receptors in the dorsal horn. I start having an axon terminal that is creating more neurotransmitter. And so it starts to rev up this vicious cycle, right? I have the ticking, I have the windup, and I have the chronic changes due to a release of glutamate and substance P from the dorsal horn and the spinal cord. And ultimately, what have I done in the spinal cord? I've created a memory to this painful stimulus. I have walked the trail to school so much that I've worn a path. Does that make sense? So your top picture here is just a, kind of an explanation of peripheral sensitization. You get this tissue damage, you start to activate these nociceptors. When you damage cells, what do you release? You release things like hydrogen ions. When you damage cells, you may release histamine. Right? The nerves around them are going to respond, and they might release some norepinephrine or bradykinin. But all of these mediators of inflammation develop at the peripheral site, and they change the threshold of your nociceptors, making them easier to fire. The bottom picture here is trying to explain the difference between allodynia and hyperalgesia. Allodynia is when you have something that normally doesn't hurt is now painful. Hyperalgesia is when you have a stimulus that will usually hurt, but now hurts more. Well, I should say that it does. This stimulus will hurt, but with hyperalgesia, it will now hurt more. You good so far? Any questions? Now here's a visual for you to understand what is going on at the dorsal horn. You don't have this picture. I'll send this picture out. But let's look at this electron microscope of a presynaptic interface with a postsynaptic neuron, right? At the top here with the yellow vesicles is your presynaptic neuron. At the bottom is your dendrite, your sensory area, your postsynaptic area. And what has happened from A to B? So there's an increase in postsynaptic density, that's what it's called. And these little black dots are all what? Receptors. That's a stronger synapse. It's easier to send a message. The more receptors you have, the more of a depolarization you can create. Is everybody tracking? And I'm trying to put these pictures with the cartoon representations that you have so you can have kind of a better understanding. And I'll send this slide out to you all individually, or I'll post it on Blackboard. Are there any questions on what's going on here? Robert, why is acute pain acute pain? Yes, so exactly. He said it's a temporal relationship, and I agree 100%. Right? If I have a chronic release or a huge release of glutamate into the synapse, then yeah, I'm going to make changes that are going to end up increasing my postsynaptic density, increasing the number of receptors I have. But if I have just a single stimulus, the glutamate diffuses across, creates a response and then it's gone, I'm not going to have a stimulus sufficient to create those changes resulting in that increased postsynaptic density. So now what's going on with that? Let me orient you to this dorsal horn picture here. We have up at the top, we have a primary afferent neuron. Where did it begin at, Kristen? If this is a primary afferent neuron, where did it come from? The surface, right? It's connected to a nociceptor that received a noxious stimulus and then transduced the signal, and it's sending a response on the primary afferent neuron. Now on the bottom is representing the second order neuron in the dorsal horn of the spinal cord. In what lamina? 1, 2, or 5. Now, these receptors that you see here are some of the major players in this whole response. And these two enzymes, protein kinase C and nitric oxide synthase, are also major players in this response. So what happens? You receive this stimulus from the periphery. You release some glutamate, you release some substance P. Now, glutamate here is in the green, substance P is in the red. Where is the green going to bind to? NMDA, AMPA, kainate. They don't even bind to this metabotropic glutamate receptor. Do you like that question? mGlu-R? You're like, what is that? That's an mGlu-R, metabotropic glutamate receptor. But the AMPA receptor, the kainate receptor, and the NMDA receptor are all ionic. You open them, ions move through them. That is their second messenger. Because a metabotropic receptor depends on a metabolic process to deliver its second messenger. So, we get AMPA bound, we get sodium in, we get potassium out, and this is going to happen with all three of these receptors. And it'll bind to the AMPA, the kainate, the NMDA, but the NMDA is only going to be partially open. Mark, why do I say that? Yeah, it's still got a magnesium bound, so it's only got partial activity right now. And so if the glutamate can go away in a sufficient time, will I release that calcium? I will not. This calcium here is the devil. Or release that magnesium. It will not. I'm sorry, I've got calcium on the brain. The goal is to keep calcium out. The goal is to keep calcium out. So if the glutamate is released and it immediately goes away after it sends its signal, then you're not going to have any problems. But if it is sufficient enough, if there's enough of it or it's prolonged, you're going to create this depolarization that is sufficient to do what? Because what is, yes sir?
Is it the little potential that's on where the
All three of these. So these will all three open.
But then it's the same thing that we've been doing all along. Nothing.
Nothing different.
Out and enough potassium.
Depolar, sodium in, potassium out, yada, yada, yada.
And that's going to kick that.
But if I stay at a certain threshold for a certain amount of time, right?
It's slow when you're not
And then when I hit a certain voltage, when I hit this certain voltage, that magnesium starts to kick off. Huh? You're having continued action potential. If this is chronic pain, this is either a huge injury, one time, or you're having that temporal relationship to where you're just, you're chronically in pain, you're chronically hurting. I keep cutting you. So I have a massive amount of glutamate, substance P, in the synapse. So that's, if I have enough of it there, I'm going to keep depolarizing this dorsal horn. If I keep depolarizing it for a sufficient amount of time and I reach a certain voltage, that magnesium comes off of that NMDA receptor. And now All hell's breaking loose. Because NMDA receptor is one of the very few voltage and ligand gated channels. Right? Initially, the glutamate with its coagonist glycine, that's in case you have to read that, that's going to partially open that receptor. Sodium goes in, potassium goes out. That's cool. As long as the glutamate goes away, you're not going to have any changes. That magnesium's not going to get kicked off. But if you keep that dorsal horn depolarized long enough, that magnesium pops off, and now you allow the entry of calcium. You tracking there? Either we have continued stimulation, or we have such an injury that we're spilling glutamate everywhere. Now, this calcium comes in, and it's going to kickstart, it's going to help activate protein kinase C. And what do protein kinases do? They pee on things. So that protein kinase C is going to phosphorylate nitric oxide synthase. And what it does is in its name. It synthesizes nitric oxide from the amino acid L-arginine. And you have that floating around in your cells. Nitric oxide synthase. So now nitric oxide is released, and it does a couple things. The mechanism not important right now, just the concept. It's going to inhibit interneurons in the area that are containing your endogenous opioids, and it's going to further facilitate the release of neurotransmitter from the axon terminal of the primary afferent neuron. Okay, so two things nitric oxide does. It inhibits your own body's pain-relieving mechanisms, and it increases the amount of noxious glutamate and substance P in the synapse. So guess what? More substance P, more nitric oxide, more depolarization. The longer calcium stays off of the NMDA receptor, or magnesium stays off of the NMDA receptor, the more calcium comes in, the more nitric oxide that's made. Do you see how this becomes cyclical and how hard it can be to treat chronic pain if that afferent neuron is constantly sending signals? All right, so I get that. I get why nitric oxide does that, but how do you get more black on your neuron, right? That picture you showed me, it went from a little neuron with a little black receptors on there to that dendrite that had this huge, big, thick black mark of receptors. Well, that is genetic expression. That is protein synthesis, and that begins with receptors like the neurokinin 1 receptor. So that's where substance P is known as one of the most painful substances known to man. P for pain. Substance P will activate neurokinin 1, for example, not only, but for example, and neurokinin 1 will send second messages that will kickstart genes, central dogma, all that good stuff, and you end up with proteins like, not only, but like CPOS and CGen, which are associated with increased pain responses. Any questions on that? Yes.
So,
I don't know what to ask you, sir, so I'll get back to you. Gotcha.
well, just with the, I guess, upregulation of these receptors,
Yep.
right? Why is it that with like addicts and stuff like that, you end up getting like a downregulation if they're constantly exposed to a substance?
That's a good question.
The opposite.
I can't answer that.
Right. That's good.
Because this is depending on an ion calcium, which is increasing this synthase, and this neurokinin 1. It's all about the genetic expression. For some reason, so neurokinin 1, maybe that gets downregulated. but now its byproducts don't. See what I'm saying?
Yeah.
If I chronically stimulate beta 1 receptor, just for example, beta 1 has nothing to do with pain. This is just an example. If I chronically stimulate beta 1 receptors, I am stimulating that pathway, beta 1. So the body says, do I need to make more beta 1 receptors? No. So I can start to get rid of some of them. This process here, when I activate neurokinin 1, or when I activate beta 1, that is going to create the expression of other proteins. And those other proteins, maybe some of them are similar to neurokinin 1, because neurokinin 1 is not the only receptor that is going to increase these types of proteins. It's not going to they're not the only receptors to increase the message to the genes to make receptors that will receive information.
I think you said it earlier. The acute stimulus were not upregulating. So these guys have a higher pain threshold because they're on a pain medicine to suppress it. So they're going to downregulate their pain receptors. So they don't stimulate it as much.
I wish pain was as simple as you would think pain would be simple, right? You treat it, you get these receptors, you give drugs, but man.
So is the question, why doesn't it downregulate?
Why don't these receptors downregulate? And I agree, it seems like they should, but they do not. Because these, one thing I forgot to tell you, these, where do you think those receptors come from? Probably the genetic, well, I definitely know, it is directly related to the message of substance P. So if I stimulate neurokinin 1, that pathway will eventually place more AMPA and more kainate receptors into the dorsal horn, more NMDA receptors into the dorsal horn. Because I'm stimulating, maybe NK1 does downregulate. I can't say that for sure. But that pathway creates other receptors. So you start to make more and more receptors that are not necessarily that receptor. Yeah.
Is that quite to prolong the putting them on ketamine for a long period of time to reset?
My dissertation or my master's thesis in your seats was use of ketamine as a preemptive analgesic, and we'll get there. It's coming. Because it seems like if you can block the NMDA receptor, you avoid a lot of this. And there's a lot of truth in that. Well, if you can inhibit this NMDA receptor with something that's not affected by voltage, then you don't see that change, that plasticity along the dorsal horn. Because it's all about that NMDA receptor. 5 days is enough time for protein changes to occur for that dorsal horn to hopefully reset. Exactly. And I'll bet you that if you could slice them open and stain their nerves, they would go from that dark blackness to a lighter shade on those dendrites. All right, so I know you're going to have questions about chronic pain. Don't sweat it right now. You guys are studying for tomorrow. Just listen. Referred pain. We all have seen it, I hope, or hopefully not. Somebody has a heart attack. Where do they feel it? The shoulder. You start pulling on a female's uterus because they're doing a C-section, they're going to feel it in the shoulder. And why? Because the innervation of the visceral organs coincides with the innervation of a dermatome, of a peripheral field. And so if I'm tugging on the gut, or if I'm tugging on the uterus, I'm releasing excitatory neurotransmitters that just happen to find their way next to their neighbor, right? That primary afferent that is in the sensory homunculus that's responsible for the perception of shoulder pain. That's referred pain. Now, with this pain response, let's go back and revisit the initial injury, if there is one. If there's a cutting tissue injury or a crush injury, something that's going to cause tissue to be disrupted. The things that you're going to release with that tissue disruption are things like bradykinin, are things like serotonin, ATP, histamine, potassium. And all of those things will sensitize that peripheral nociceptor and make it easier to fire, make it easier to send information. That's that swelling you see. As well, you will see vasodilation in the area because some of these substances will cause dilation. Some of these substances, check this out, let me get there, will actually act on nerves surrounding the site of injury and cause them to act on, how do I want to say this? If I've got 3 connections, and I send electricity down one, electricity sometimes will find its way out the others. And so I can actually release neurotransmitters from the nerve ending onto other organs, which will then release mediators of inflammation, which will then cause the peripheral nociceptor nerve endings to release more of that information, and so on and so forth. That's a cyclical process. But typically these nociceptors should only transmit information. But in this scenario, they also transmit information and will send information juxtaposed to other areas via current. Right? Okay. Whatever. Once again, let's talk about that afferent pathway. That afferent pathway is going to travel up one of your dorsal horns, or travel from your dorsal roots into your dorsal horn. It's going to find its way into the dorsal horn. It's going to have lamina there that it synapses with. And then it's going to be modulated. Speed up. What determines the speed of conduction in a nerve? Diameter of fiber as well as myelination. So, do you think C fibers are myelinated? They are not. Do you think A delta fibers are myelinated?
Yes.
Yes, they are. Excellent. Which ones are easier to block? The chronic pain, absolutely. So here's a couple pictorials of a visualization of those lamina and how that primary afferent neuron will find its way into the dorsal horn. And then at the bottom is a picture of where it might synapse with a second order neuron. Gives you a visual of that. Now, once it decussates with that second order neuron, what 3 pathways did we talk about that signal could go on? Spinal thalamic, spinal reticular, and spinal mesencephalic. Those will be the ones that you have to know. The spinal thalamic helps you perceive and localize pain. The spinal reticular increases your awareness. The spinal mesencephalic kickstarts your descending pain pathway to treat your own pain. This is kind of very much a review, but we'll keep doing it. The primary afferent neuron receives its information at the nociceptor, transduces that information, and sends it up the first order neuron to the dorsal horn, at which time it will release glutamate, some substance B, onto the postsynaptic target, which is a second order neuron. At that point, the glutamate comes and binds to AMPA, kainate, NMDA receptors, and causes a depolarization. If that depolarization is sufficient, what part of the second order neuron will determine if that depolarization is sufficient? see if I can remember your name. Axon hillock. So at the axon hillock, all of those charges are summated, and if you depolarized enough, you send up a signal through the second order neuron. That second order neuron finds its way across the spinal cord, right? It decussates, and it goes up the contralateral side to the thalamus. So what did I just say, Christopher, in a nutshell?
You got first, second, third order neurons all
Focus on the go across and ascend rostrally. So if I cut across the spinal cord, what does that tell? What part of your body senses pain relative to the other part?
Oh, opposite.
Right. So your opposite side. If you are sensing pain on your right side,
Left side of the brain.
it's going up to your left side of the brain. So let's talk about these tracts. So the spinal thalamic tract. Fabiola. I should call it the spinal thalamic tract. Let's call it spinal thalamic. All right, it starts at the spinal cord, goes to the thalamus. The spinal reticular starts at the spinal cord, goes to the reticular formation. The spinal mesencephalic tract starts in the spine and goes to the midbrain, the mesencephalon. That's why they're named the way they are. So, the spinal thalamic tract is a three-order system. It starts in the dorsal horn on the side of the stimulus. That second order neuron will cut its way around, or cut its way through the spinal cord. On the opposite side, ascend rostrally up to the thalamus, in which it will hub with a third order neuron. And that third order neuron will go to the somatosensory cortex, and you will perceive your pain. The reticular formation. There's spinal thalamic. Spinal reticular formation. This one is the one that's different. Oh, I'm sorry, not this one, the next one. The spinal, no, it's this one. The spinal reticular formation. Now this could be a 2 or a 4 neuron system. A 2 or a 4 neuron system. So let's think about that. We've got the first order neuron that comes in, and it synapses with this second order. All right. And this second order is going to go to one, for your purposes, one or two places. It's either going to go to the reticular formation of the pons or the reticular formation of the medulla. Now, if it goes to the reticular formation of the medulla, it stops there. It creates a generalized sense of awareness. If it goes to the pons, it's going to synapse with another neuron that is going to augment. It's meant to augment your pain perception. Now that third neuron in the spinal reticular tract goes to the thalamus from the pons. It finds its relay, and then that fourth neuron will go to the somatosensory cortex. So the purpose of the third and the fourth neuron in this spinal reticular tract system is to augment your perception of pain. Does that make sense? Now, what do you think is, what kind of things are located in the medulla? Cardiovascular center, your respiratory center. So when you get excited, what happens? Heart rate increases, blood pressure goes up, and you start breathing a little bit faster. I might vomit too. But is that does that make sense to you physiologically why that would happen? Generalized sense of awareness is increased. Now, one of my favorites, the spinal mesencephalic tract. This is going to initiate the descending pain pathway. This is one neuron that goes from the spinal cord to the midbrain, right? Or to the periaqueductal gray. Now you're going to get to know this diagram very well. And it looks intimidating, but it's really not. It's really not intimidating. We're going to go over it. Those are just words, but we're going to go over it here real quick. All right. Maybe not real quick, but we're going to go over it. So imagine the dorsal horn in a box. That's what the bottom of this box represents, the dorsal horn. And then you can jump up to the medulla, and then you can keep going up to the pons, and then even higher up into the midbrain and the brain. Okay? Now, notice the red dots. For your purposes, those red dots represent a tonic or a continuous GABA release onto those neurons where the red dot is next to. Major Wimmer, what does that mean then? If I've got a red dot next to that glutamatergic neuron, or I've got a red dot next to that serotonin neuron, what does that mean? Huh? It's constant. There's a constant release of GABA onto these neurons for your purposes. So you're inhibiting, at rest, you're inhibiting this glutamate neuron and that serotonin neuron. Everybody, that's an important part of this. All right? Because you don't want your descending pain pathway to continuously fire. So you have mechanisms in place to put the brakes on it. Now, you feel pain. My son comes and tackles me and I hit my head on the ground. Bam, it hurts. There's my red, or he steps on my toe. There's a green little oval over this primary afferent neuron to represent a stimulation. Right, so this primary afferent neuron receives the noxious stimulus, represented here in green, and now that first order neuron is doing what, Monica? Synaptic what? It's a second order neuron. A second order neuron. And in this case, the second order neuron could be one of three paths. But in this particular pathway, it is representing the spinal mesencephalic tract. Now, the spinal mesencephalic tract is going to stop at either the locus ceruleus or the periaqueductal gray. Now, you're going to get some immediate pain relief, believe it or not, as a result of the locus ceruleus. Okay? So the green blobs represent excitatory neurotransmitters being released onto the neuron it's next to. So Freddie, I've got this glutamate neuron, the second order mesencephalic tract neuron. It is synapsing in the locus ceruleus, otherwise known as the blue spot. Locus ceruleus. It's called the blue spot because norepinephrine, when you take it out, in that area looks blue. So if it's the blue spot because of norepinephrine, what kind of neurons do you think come from it? Norepinephrine-containing neurons. All right, so this glutamate gets released onto this noradrenergic neuron. Now what?
Comes back down.
Okay? And it's a red dot. But wait a minute, sir. You said green means stimulatory. Yes. And red means inhibitory. So what adrenergic receptor might be inhibitory? Alpha 2. And so I release norepinephrine. Right? This norepinephrine neuron gets into the mix and releases norepinephrine. It finds the alpha-2 receptors located on the dendrites of the neuron, and what kind of potential is created? IPSP. Is this physiology ringing a bell? So, I release norepinephrine onto the second order neuron, and I stimulate a GI protein. I create an inhibitory postsynaptic potential. And so if I have an inhibitory postsynaptic potential, and I go to the axon hillock, that's a negative charge. It's going to be harder to fire. So I have some pain relief. I know I'm laboring this, but it's important to get this. All right, so that's your immediate pathway, right? And right away that happens. And very shortly afterwards, you start to see the other indirect pathway. So the next part of that spinal mesencephalic tract heads up to the periaqueductal gray. You may hear it referred to as the PEG. Now there are cell bodies of 3 neurons in that area that you need to be concerned with. One being enkephalin neurons, one being GABA neurons, and one being glutamate neurons. Now, I am sending a glutamate projection to the midbrain, to the periaqueductal gray. I release glutamate onto this enkephalin-containing interneuron. What will glutamate cause from that enkephalin interneuron? Enkephalin release. Right? So I release glutamate, I excite the enkephalin neuron. That enkephalin neuron releases enkephalin. And what do you know about enkephalin? It is an inhibitory endogenous opioid. So what type of receptor, G protein receptor, do you think it stimulates? GI, mu, not M, mu. So there's muscarinic and then there's mu. So it's going to stimulate a GI protein, a mu receptor, on this GABA. This is where it gets tricky now. So I'm releasing an enkephalin, which will stimulate an inhibitory receptor onto this GABA neuron, which is chronically releasing GABA. What now will happen? So, will that red dot go away? Yes. Right, so I release the enkephalin, which is inhibiting that GABA neuron. And why is it inhibiting? Because it's activating a GI protein, which is inhibitory. So it shuts down this GABA interneuron, and now I have taken the brakes off of this glutamate neuron. So what's going to happen with that glutamate neuron now?
The environment's going to activate it. So
Yep, it becomes activated. Do I need to go through that again? We'll listen to it, sir. Don't worry about it. Keep going. We ain't listening to you anyway. Gotcha. So now I release glutamate into the raphe magnus of the medulla, another important part of the descending pain pathway. And we got the same configuration here. We're releasing, or we are exciting this enkephalin interneuron. That enkephalin interneuron is going to release a substance which then will inhibit a GABA neuron that has been chronically firing. Now that GABA neuron is turned off, right? That red dot goes away. And now I take the brakes off of this serotonin. So serotonin gets released onto, in the dorsal horn, serotonin will excite more enkephalin interneurons. And when I excite those enkephalin interneurons, I will release endogenous opioids, which will help to inhibit the second order neuron at the dorsal horn. Yeah, imagine researching this to make sure I had it right. I have a YouTube video that you know about that goes over this and over this and over this. So there's a lot of inhibiting the inhibitor here. Make sure your words are appropriate. If you can get a grasp on this, this will help you with your interactions with pharmacology. There's a lot of stimulating an inhibitor which inhibits an inhibitor, right? Any questions on that?
I don't know, sir. Do I?
All right, so there are two different ways you can mediate analgesia, at least two different ways. And you're going to hear a lot of talk about spinally mediated analgesia and supraspinally mediated analgesia. What do you think that means, Matt? Okay, one's talking about the spine and the other one's talking about the brain. That's right. So you can modulate pain both in the spinal cord and in the brain. The brain is where you perceive it. The spinal cord is where you transmit it. What's another obvious place that you can modulate pain? In the periphery, because that's where it's transduced. Another place would be along the axon. That's why you do nerve blocks, to stop the conduction, the transmission of the pain. What receptors will help in pain relief? Mu opioid receptors, right? Sodium channels, alpha-2 receptors. Why did you mention those, sir? Well, that's the classes of drugs we're going to go over. Local anesthetics. Right? We're going to go over opioids. And then we're going to talk about affecting a mediator of inflammation with the NSAIDs. So this picture is to help show you where you can treat pain at. You can treat it at the nociceptor with a field block. You could do a regional block and treat the peripheral nerve. You could actually cut the dorsal root. You could give a spinal anesthetic and hit the spinal thalamic tract. You could take a systemic opioid to hit both the brain and the spinal cord. So imagine you are that molecule. Where are you going to treat that pain? Okay. Also look to the side here. That's what we're discussing, with the exception of the alpha-2 agonist. But I think you have a grip on that. This is just another picture. I like pictures. Before we move into the local anesthetics, any questions? I think I've fried your brain enough. We'll see you later. That pain pathway sucks, sir. You're right.
That wasn't that bad, sir.
Here's the memorization of the roadmap.